Dr. Anuja Dokras, who's a director at the Penn PCOS Center. She's also an associate executive of the AEPCOS Society. She's the past president of the AEPCOS Society, and she's the director at the Hospital of the University of Pennsylvania Reproductive Surgical Facilities. She's also the director at the Gynecological Team Women's Health Service Line, University of Pennsylvania Health System. Her areas of interest are long-term cardiovascular disease risk in reproductive age and menopause, psychiatric disorders including depression, anxiety, body image, distress, and eating disorders, and advocacy for awareness, education, and research related to PCOS. She would talk to us today on factors affecting ART success, which include obesity, androgens, insulin, and LH levels. Dr. Anuja.
Hi, everyone. Thanks, Madhuri, for that introduction. Nice to see everybody on the screen. All right, I'm going to go ahead and share my screen here. Can you see my screen?
Yeah, we can.
All right, okay. So as Dr. Madhuri said, my topic today is to talk on factors affecting the success of ART and PCOS. And let's just do a recap of what is disrupted in the endocrine milieu in PCOS. I'm sure most of you are familiar with the basic pathophysiology associated with PCOS, but I think it would be a nice introduction sort of to review what factors might ultimately impact the success when our patients go through IVF. So we have the aberrant LH secretion from the pituitary, primarily linked to GnRH abnormalities and in the pulsatility of GnRH from the hypothalamus. And as a result of which that drives excess androgen secretion from the ovaries. It also disrupts folliculogenesis. And as you heard earlier, we don't get the monofollicular growth and just a number of preantral and antral follicles within the ovaries. The second abnormality is the increase in the androgen levels, and even in those patients where we may not detect a very high total of free testosterone in the serum, the ovarian milieu might be altered, and as a result of it, again, resulting in more pre and antral follicles rather than the dominant follicular growth. The other abnormality is high insulin, and that is secondary to insulin resistance, both at the level of the skeletal muscle, adipose tissue, and that'll then drive increased androgens again from the ovaries. So two mechanisms by which we may have hyperandrogenemia, down the hypothalamic pituitary pathway, as well as through the stimulation from insulin. And so these would be our targets to improve ART success. And then you heard a little bit about AMH from Dr. Sujata and how those levels are high in women with PCOS. And what is the impact of that finding? It's a marker of ovarian reserve, but how does that predict outcomes? And also we have unopposed estrogen, right? And so this might result in impacting implantation rates. Androgens can have an impact as well on the endometrium. And so a combination of what happens with respect to folliculogenesis as well as implantation could affect our ultimate success when our patients go through IVF. So with that background, let me also share what are the other risk factors in our patients, unlike patients who are going through IVF, like for tubal factor or male factor. This is a different group that's going through IVF. First of all, it's different because the group of women who come, of women with PCOS who need IVF is a different subset than those who get pregnant just with clomiphene or with letrozole. And so you already have a subset of PCOS and they have a high risk of comorbidities. So we know very well that women with PCOS have increased insulin resistance just as their baseline pathophysiology, but they also may have increased hyperlipidemia, obesity for sure, a high prevalence of diabetes. And if they don't have the full-blown metabolic issues, they may just have pre-hypertension, pre-diabetes, which puts them at risk of what we call metabolic syndrome. They also have an increased risk of mood disorders. And so all of that might play into our final outcomes and success of ART. So then let's ask the question, like when our patients go through ART, what is the success in somebody who has a diagnosis of PCOS versus a control patient? And so what do I mean by a control patient? Here is a study that we did quite a few years ago now, when we looked at a very large registry in the United States. It's known as SARP, the Society for Assisted Reproduction and Technology, where all the IVF centers just voluntarily give their data on an annual basis. So this was a large registry that we could look at, and we said, let's look at tubal factor, because this is a nice control group. The only reason they're having IVF is because of a tubal pathology. And let's compare them to PCOS patients. And as you can see here, if you look across age, as you would have expected, they give us a high number of oocytes throughout, even all the way into the higher 30s and the age of 40 and beyond. And that's fine. And then you might say, but what about the actual clinical pregnancy rate and the live birth rate? And you find that the live birth rate continues to be higher right through the different age groups. Again, suggesting that our patients with PCOS, when they reach IVF, in general, have a very good outcome compared to other causes of infertility. So now we're really saying, so of these women who have a generally good outcome, what else can we do to improve their outcome and their success? And so the question is, how do we define success in women with PCOS who are going through ART? And our field over the last decade has really moved quite a bit to say, we really need to consider success as a singleton live birth. And now we've gone on to say it should be a singleton live birth of a healthy baby. I would say that in PCOS, we really need to define success as a singleton live birth of a healthy baby to a healthy mom. And the reason we say that is, of course, I've already shown you that women with PCOS are not always the healthiest. In addition to that, during pregnancy, they're prone to a number of complications. So there's very good data to tell us that women with PCOS have a high risk of gestational diabetes. They have a high risk of preeclampsia, preterm delivery, cesarean sections, and now good data to say an increased risk of perinatal and postpartum depression. So really, when we're taking them through IVF, we want it to be successful such that at the end of this pregnancy, they're not at a higher risk because of these complications that might have occurred. And how do we make sure that they go through that entire process so that we have a really successful outcome? So here are some prediction models that have been used for all comers in IVF. This is not data that's specific to PCOS, but if you had a patient going through ART, how would you predict her success and what are the factors that influence it? And prediction models have been reported using data from Europe. This is from the UK. And here is another study using prediction models from data from the US. And pretty much irrespective of the population, what the data says is that the factors that predict outcomes of ART are BMI, age, ethnicity, gravidity, and then cause of infertility, where PCOS comes under that ovulatory dysfunction. And again, as I showed you in that very first or second slide, in general, having a diagnosis of PCOS is a good predictor of outcome. But this really doesn't tell us what is the predictor specific in a woman with PCOS, right? It just tells us for anybody who comes to our office. So here is a study that looked at women specifically trying to get pregnant and those who had a diagnosis of PCOS. And the outcome here, so always we're looking at an outcome of live birth, not just pregnancy, not a biochemical clinical pregnancy, but going all the way. This study looked at not ART, but using clomiphene, metformin, or a combination. And I just wanted to use it as a starting point to highlight that in addition to the other factors that we heard about, and BMI being one of them, hirsutism score, so as a surrogate for hyperandrogenism, resulted in significantly lower pregnancy rates. So if you look at the red and the orange bars are the lowest pregnancy rates. This is after undergoing 6 cycles of either clomiphene, metformin, or the combination. And in general, the red and the orange, as you can see, give the lowest success rate, but with the highest hirsutism scores. So what are our targets then? In order to improve success in women with PCOS, we need to target their BMI and maybe their androgen levels. And so let's start with assessing what is the impact of BMI on pregnancy outcomes in women who go through IVF. And now again, this is looking at all comers, not specifically for PCOS. And again, as you can imagine, most of the data is for all comers. And then I'm going to show you slides and some studies specific to PCOS, and which are usually a smaller subset. So here is data looking at the outcome of BMI, and you can see the BMI listed here up to 40, normal weight, and these are the pregnancy rates are pretty flat. And as the weight goes up, pregnancy rates continue to drop through overweight into obese, and the live birth rate tracks very similar to what you see for the pregnancy rate. Not surprisingly, and we know this, the impact of BMI on miscarriage rate. And as we trend up on weight, we find that our patients have a higher risk of miscarriage. Prior to the live birth and pregnancy, we also know as you stimulate obese women, they have a higher risk of IVF cancellation. We get fewer oocytes and fewer usable oocytes. And the definition of that being fewer of the fertilized embryos actually reaching the blastocyst stage and being available either for transfer or for freezing for another pregnancy. So again, you might say, does that apply to women with PCOS? And so the impact of BMI specifically in women with PCOS, here is a more recent study. There have been a few smaller studies previously, but a lot of them just control for PCOS and use it as a variable. And the question we're trying to say is specifically in a woman with PCOS, if she is obese, does that decrease her success going through IVF? And you can see here the success of number of usable embryos starts decreasing more, under the obese rather than in the overweight group. And again, the ongoing pregnancy rate starts dropping. And in this study, at least more specifically with the BMI over 30. And again, this is important in terms of the audience here today and what are the BMIs that you're seeing versus, what we see in the US, which is quite different. But there may be some advantage that the drop occurs a little later because we do get a larger number of oocytes from our patients with PCOS. So again, coming back to, is live birth all that we're looking at? And no, we're really looking at a successful outcome as defined by the complications associated with pregnancy. And so I wanted to put in this slide from, again, a recent study that looks at the effect of obesity on singleton pregnancies after IVF, and looking at maternal outcomes here, gestational diabetes, hypertension in pregnancy, and preeclampsia. And even at a BMI between 18 to 25, they began to show a difference in gestational diabetes and certainly a BMI over 25. So this is not over 30 now, it's over 25. And again, may correspond a lot more with the Indian population in terms of BMI ranges. And we find that there's an increase in gestational diabetes, hypertension, as well as preeclampsia, and then C-section rates. So really no specific data looking at a group of women with PCOS, and if they have metabolic risk factors, what does that do to ART outcomes later? There's data on BMI. And so here is data, which is our own data, unpublished right now, so sort of hot off the press. When we looked at, and this is between 4 IVF centers in the US, looked specifically at women with PCOS, those who did not have a live birth and those who had a live birth. And then as you can imagine, those who did not have a live birth, they have a higher BMI, or the normal BMI is a lesser proportion. What was most interesting is when we looked at metabolic risk factors. So these are women who had high lipids, a little bit of prediabetes, a little bit of prehypertension. What does that do to the success of IVF? And in the no live birth category, we had about 65% of patients had some metabolic risk factor. So again, saying this might be a good target, that if we are able to improve their metabolic profile, we might get better outcomes from ART in this population. The other group I want to show here that Dr. Sujata talked about in the last lecture was the ones who do not respond to clomiphene and letrozole, or the non-responders. The non-responders do much better with ART. And so again, as you can imagine, that's a good cohort. They just did not have a response to the oral medications. If you move them to ART and you're able to get them to respond to the gonadotropins, they do much better than the ones who do not respond. So when we put all of these together in a model, so these are our different factors that will improve ART success in women with PCOS. It's so interesting that if you look at this lowest line, the youngest patient, normal BMI, non-responders, PCOM morphology had one of the highest success rates. And then as you keep going and changing these parameters, the success rates can get quite low. But the takeaway here is, where is the metabolic risk gone? So the metabolic risk trends very closely with BMI. And so that came out of our model, telling us that if we really target BMI, that's what's driving a lot of these abnormalities. So the next sort of half of my talk, I'm going to talk about what are the strategies to help our patients lose weight in order to improve their outcomes from ART, because really most of our studies are showing us that BMI is what is influencing the outcome in our patients with PCOS. But before I jump to BMI, let me sort of review the layout in which I'm going to talk about these treatment options. So one is lifestyle modification, and we'll talk about diet as well as physical activity. Then what we all commonly use is our insulin sensitizers, metformin and inositol. And then a little bit about weight loss medications, which have become quite popular now in the US, and we're using them commonly, and then bariatric surgery. So lifestyle modifications and diet has been very frustrating for our patients. You know, there's no specific diet that's recommended for PCOS, and they really want to know something very specific that they can follow. The international guidelines that we referred to a little earlier did not recommend one specific diet over another, and in fact said that, you know, you need a behavioral strategy that should be, we use sort of the SMART approach, the specific, measurable, activating, realistic, and timely. Having said that, the nutritionists in our program really prefer to recommend a low carb diet and a high protein, because most women with PCOS are quite sensitive to carbs. And so cutting the carbs and reducing them does help in getting reasonable amount of weight loss. With respect to exercise, again, to keep in mind, there's two things here. One is, are you trying to get your patient to prevent weight gain, or are you actually encouraging weight loss? And that's much harder. Doing exercise in order to lose weight and actually achieve weight loss is much harder and requires quite some rigorous exercise and commitment to doing exercise throughout the week. And so we again find most of our patients are not compliant to a great extent with exercise recommendations, and they do much better with the dietary recommendations. So what is the outcome of lifestyle modification? So the combination, both diet and exercise, on ART outcomes. And here are three sort of studies that I pulled out just to give you an overview, again, in all comers. This is women going through IVF, not necessarily PCOS, and small studies. Here's an Italian study that talked only about physical activity. And their conclusion was those women who reported more physical activity actually had better outcomes than less, but it didn't really significantly show a difference or tell us, you know, what kind of activity would result in an improvement. Similarly, there's another smaller study from Australia talking about diet and IVF outcomes, and a pilot study, again, suggesting that some weight loss through diet might improve IVF outcomes, and going only to clinical pregnancy rate. The more disappointing one was the larger study that was published a couple of years ago, and now their follow-up, which came from Europe, and they engaged some of their women in weight loss interventions as they were waiting for IVF, and then the second group that went directly to IVF, and did not find a difference in ART outcomes between the two groups. So very disappointing. But again, I want you to keep in mind that these are not women with PCOS, and the PCOS profile might be quite different, because as we saw, BMI and metabolic risk are very closely linked in women with PCOS. And if we are able to engage in weight loss and PCOS, that might actually improve outcomes because of that link, because of the endocrine milieu of hyperinsulinemia and some improvement in hyperandrogenism as well. So do we have data though to support that in women with PCOS? So the data I'm going to show you is our study called the OWL PCOS study, which was oral contraceptive pills and weight loss, and hence the name OWL, which we published a few years ago. This study included women who were overweight and obese. So this is not a lean population. They went through lifestyle modification and quite intense. So not just dietary changes, a little bit of meal planning, as well as a weight loss medication combined and exercise. So they had a coach and a nutritionist helping them for 4 months, or birth control pills for 4 months, or the combination. So what was the idea here is to improve insulin resistance, because that's one of our predictors of outcome, improve hyperandrogenism, because the birth control pill will drop that, or the combination. And if we do that and then follow it by clomiphene for 4 months, 4 cycles, will that improve our live birth rate? So this is not an ART or IVF outcome, but still it'll give us some strategies as to what should we do with our patients who come to IVF. And so here are the results. So in terms of weight loss, about a 7-kilo weight loss in the lifestyle management and the lifestyle plus birth control pill group. Interestingly, no weight gain in the birth control pill group. Our patients are always worried that they're going to gain weight on OCPs, and this group did not show any of that. What I don't have here is both of these groups had improvement in the insulin resistant markers, so the fasting insulin, HOMA-IR, and the group with birth control pills and the combination had marked reduction in androgens. So now we're targeting both of these two endocrine abnormalities that are common in PCOS. And what did we find in terms of live birth rate outcomes as compared to the red line, which is the birth control pill success rates? These are the green line is the combined group, birth control pill plus lifestyle and lifestyle modification. So really improvement of the hyperinsulinism, insulin resistance pathway seemed to give us better outcomes rather than improving the hyperandrogenism pathway. And in fact, the metabolic risk factors improved in this group, whereas the birth control pill group had slight increases in triglyceride as well as blood pressure. So again, in our practice, yes, all our patients will see a nutritionist. And as I said, we tend to recommend a low carb diet. But again, that is much hard to sustain, as we all know. So what about insulin sensitizing medications? And these are very commonly used in women with PCOS. And as you know, metformin has been used for several years now. So what do we find with metformin? We do know that it can cause a decrease in weight, and that's been shown by a number of studies, one meta-analysis earlier on in 2009, and then it was updated. In general, the weight loss is modest. It's not a lot. It's not a first-line weight loss agent, but we do see some amount of weight loss in our patients and some improvement in metabolic profile. The question is, does it improve pregnancy outcomes? And this is a very recent paper, hot off the press, and I was very happy to see a JAMA network publication for PCOS, so we get a lot of high-profile attention here. And so what this study showed in a systematic review and a meta-analysis was the risk of OHSS, and I know there's another talk later that will address this, but was significantly improved, or the lower risk of OHSS in women who have been treated with metformin and going through IVF. This is specific for PCOS now. So what's more interesting for us is the clinical pregnancy rate in those patients who are obese was significantly higher. And then the live birth rate was higher, did not meet statistical significance. But if you look at just the obese group, it's almost making it. And these are pretty high quality studies that were put in here. So I think exciting information that we finally have this data and sort of supports that metformin during the process of IVF will give us, at least in our obese patients, will give us a better pregnancy outcome with the caveat that this is just looking at live birth rate and not the whole metabolic risk that I was talking about. What about inositol? So inositol, again, very commonly used both by your patients in India, even by our patients, because it's not on prescription. It's over the counter. It's a supplement. They can use it very easily. The data, though, is pretty disappointing. So, here's another systematic review a couple of years ago, and it mainly the studies are not a very high quality to moderate, and they're not showing any difference in terms of number of oocytes, pregnancy rate. It doesn't go all the way to live pregnancy rate. So most of the studies end at just a clinical pregnancy rate. So of the insulin sensitizers, we tend to use metformin, ramp it up, gradually to about 1500 milligrams. We use an extended release. We started, of course, even before IVF, and most of these patients, if they've tried ovulation induction, they're on it for a while. But once they're pregnant, we stop it with the positive heartbeat. If we had only started it for improvement in ovulation induction. If they're pre-diabetic, diabetic, then it's a different indication. But if it's mainly to improve the outcomes of pregnancy or to get them pregnant, then we stop metformin with the heartbeat. Very briefly, keeping in mind, I want to leave time for questions. So weight loss medications. So I listed some of the weight loss medications that are at least available in the US, and in the brackets is their brand names, and then the pharmaceutical names on the left-hand side. So the leucocerin was pulled out of the market earlier this year because there was some risk of cancer. The most commonly used medication out of this is liraglutide. And we have a medical endocrinologist who helps our patients and will prescribe this. And we see quite a significant weight loss with these medications. And the more recent one, semaglutide, which is a once a week injection, so much better. And the patients like that and tolerate that better. And the idea is to get some weight loss prior to starting IVF or starting ovulation induction. It's not to continue it later on in pregnancy. And again, not much data. So there's data to say women with PCOS lose weight on these medications, and so we know they work in PCOS, and there's nothing about the PCOS profile that prevents the patient from losing weight. The question we are asking today is, does that improve our IVF outcome? And so I've added one paper here, again, just to show you that, it has been used, not necessarily saying that we would base our entire practice on this one paper. It's a small group of patients, just 28. They were randomized to metformin and metformin plus liraglutide. And again, this is combination. It's very rare that we're going to find studies with placebo. They did it for 12 weeks and then stopped the medications, and then the patients went on to have IVF. And the cumulative pregnancy rates over 12 months are pretty impressive. In the metformin group, it was 35. The combination group, it was 69. So again, just one study, sort of a proof of concept that this can work for our patients. And finally, to show you the live birth rates after bariatric surgery. And again, this is by no means the majority of our patients. It's a very, very small proportion of our patients. But now we have more data over time. And this is a meta-analysis, a review that was put together from one center. So this is from Hector Morales' group in Madrid, that they looked at pregnancy rates. So in the BRCA women with PCOS and controls, and the pregnancy rates after bariatric surgery and follow-up. So these are women who either came back to their clinic and they don't let them get pregnant for at least a year or 18 months after the surgery. So this is long-term follow-up, or by phone call that they got the information. And the pregnancy rates was significantly higher, live birth rates trending to be higher, not significant. And this is all spontaneous pregnancy. So this is not ART, but again, important information for us to know. And the other column, which I thought this figure was really interesting, is women seeking fertility. So those women who said in a questionnaire before surgery, I'm undergoing surgery because I want to get healthy and I'm going to try to get pregnant after this. The majority who said that with PCOS got pregnant. In general, I think majority do get pregnant with this extensive weight loss and a significantly high live birth rate. So the patients do well, again, telling us that reducing weight has a significant impact on pregnancy outcomes. What we need to keep in mind, though, is that there are some studies that do talk about both obstetric complications, as well as neonatal complications in these patients. This study really did not find significant differences between groups, excepting on one parameter, and that's the mean birth weight was lower in newborns from women with PCOS as compared to the control. So again, I think it's not indicated for everybody who comes to us with a very high BMI, and there are some caveats in terms of outcomes, but something to keep in mind. So let me conclude by sort of talking about there are a lot of barriers to weight loss, but that seems to be a good target to improve ART rates in our patients. And the way that would work is by driving insulin or improving insulin sensitivity. Extensive weight loss also decreases hyperandrogenemia by decreasing the adipose tissue contribution to it. But we have a number of challenges in terms of barriers to weight loss that we still need to overcome. And so what are the things you're going to test prior to starting IVF in women with PCOS to optimize their outcomes? You know, screen for diabetes, hypertension, lipids, mental health, and then obesity, which is driving all the above. So you can start targeting this. I know you've already had a talk previously on the IVF recommendations in terms of protocol. And so just to highlight that the international guidelines did recommend a GnRH antagonist protocol, which is what we typically use for all our patients. We tend to use a GnRH agonist trigger if possible, if we are worried about the risk of hyperstimulation. And then I know there's a talk later talking when you will review a little more about a freeze-all strategy. And those are ways we could tweak the actual cycle while the patients are going through. And I had put in a few slides again to say the way we do IVF these days, the LH levels are really low because we do the pre-treatment with birth control pills for a short time. If you use an antagonist, LH levels are pretty low. So that endocrine milieu that we are worried about during IVF gets normalized because of our IVF protocols. And really what we are trying to improve is the endocrine milieu before starting IVF with strategies such as the weight management. And then the last slide that Dr. Madhuri asked me to address a little bit, and Dr. Sujata brought up as well, that when you have a high AMH, what does that do in terms of ovarian response? And there's growing data now that patients who have a high AMH are difficult to stimulate and maybe the non-responders, especially to the oral agents. So this is the data, again, from the PCOS trials. When you look at the AMH levels, the patients who did not respond to clomiphene, the majority of them with the non-ovulation, the AMH levels were higher, and the same in terms of letrozole. And the AMH corresponds to non-ovulation much more than the antral follicle count. And so again, if you have a patient with a higher AMH going through IVF, some of the strategies like Dr. Sujata talked about is, could we use laparoscopic ovarian drilling? Is there a role for that? Or do we keep increasing our gonadotropin doses till you hit that threshold, and then you'll get a response? But we are always worried that can sometimes give an exaggerated hyperresponse, and then we would use a trigger with a GnRH agonist. Again, since we don't have as much of that very lean hyperandrogenic profile with the high AMHs, we don't have a large number of patients with this problem. On the other hand, obesity decreases AMH. And so we are able to get the response and in a lot of cases increase our dose, because with obesity, we need slightly higher doses of gonadotropin. So it's a little bit of balance as to what AMH does depending on how obesity is influencing the levels of AMH and our ovarian response. So I'm sorry, I went a little over my time, but let me conclude by saying, we really need to define our success in ART as a singleton live birth of a healthy baby to a healthy mom. And I'm going to show you my concluding slide of our network through our PCOS Center in Philadelphia in the US, but I want to give a big shout out both to Dr. Durusha and Dr. Madhuri Patil for just putting together an amazing workshop this weekend, previously as well, for all the work that they have done with the PCOS Society. I'm I've just been so proud to see this society flourish and do extremely well. And they have been our research partners as well, both Dr. Durusha as well as Dr. Sujata. So thank you for all your contributions and inviting me today. Thank you.
Thank you, Anuja, for that excellent lecture. Let us take a few questions. Any questions from the faculty here? Duru, Sujata, Rekha, would you want to ask?
Anuja's talk has been so brilliant that honestly, there's not much to question. But I just want to know is, there have been some standards for BMI, the Asian standards, as we would say, Anuja. This is for the Indian ethnicity or maybe Asian ethnicity, where they say that since we have more visceral fat, we should consider a BMI of over 23 as overweight.
Yeah.
Whilst I think the international standards talk about it being above 25. So what do you think we should do being in India? Which standards should we follow?
So that's a good question. And I think every time you look at data, you have to say, does this apply to our population, right? Because a lot of what I showed does not apply. It's for more of a Caucasian and an obese population. And the profile in India can be quite different. And hence I put in one of the Asian studies, I think that match a little better. You have to use 23 as a cutoff. The reason being a number of studies do show even the diabetes risk in India matches with those lower BMI cutoffs. So I think it would be best to use a lower cutoff in an Indian population. What Dr. Duru was talking about is the visceral adiposity, a lot of the obesity being centrally. So waist circumference sometimes become a better gauge rather than BMI. The BMI may be in a normal range, even less than 23, but the waist circumference will be high. And those are the patients with the visceral adiposity. You get the peripheral conversion with the free testosterone being high. The total may not be high, but that's going to change the endocrine milieu as well. And I do think that population might benefit with metformin, because that's one of the targets of improving the insulin sensitivity is through the adipose tissue, because you have resistance at the level of the adipose tissue. So good question. And I think keep scaling down a little bit in terms of the BMI cutoffs that you're using and use the ones that are more appropriate to your population.
Yeah.
Sujata,
Unmute yourself.
I was saying that we need to find another marker. BMI is not a good marker, at least in our population, which is so heterogeneous in appearances and everything. I feel BMI is not a good marker. Maybe, like you said, waist circumference or some other body fat versus muscle mass or something of that nature.
And so I think the link is, so what is BMI doing? It is a surrogate. And that's why I think looking at the metabolic profile. So if you have somebody whose metabolic profile is completely normal, now we call them metabolically healthy obese, MHO. And so obesity alone may not have a negative impact if it is not changing your metabolic profile.
Yeah.
So you're right, none of these are very absolute or good markers by themselves. And hence, we try to look at the metabolic profile in these PCOS patients to say, can we use that to predict outcome? But it was so interesting that in our population, because they're so much more obese, it was highly linked and it did not really, it washed out and we could use BMI alone. But maybe in your population, you might find that the pre-diabetes or the hypolipidemia might be a better driver, and obesity may not be the sole one, and you might be able to use those. So I would suggest screening all your patients at baseline. And even if the BMI is normal, but they are pre-hypertensive, pre-diabetic, that's a high-risk group that you're going to be more vigilant about before starting IVF.
Absolutely.
There's another question that says, what is your experience with IVM in women with high AMH and who are difficult to stimulate?
IVM?
Yeah.
Yeah, we don't do any IVM, so I don't really have much experience with IVM. I don't know if there's anybody else on the panel who might have experience.
No, even I don't do.
On
I have worked in Vietnam where they have a very strong IVM program, and also they do have another one in Belgium. It's actually quite a good technique from the point of view that you don't have issues with stimulation, but the pregnancy rates are definitely lower. And the biggest issue is, in fact, doing the pickup is very difficult to get the eggs out, and you have to have a lot of surgical experience to do it. But when you have surgeons who are very well trained, they do have quite reasonable pregnancy rates without the risk of hyperstim. And the media is getting better, and they have a needle that has a very fine inner needle that they put the needle into the ovary, and then they use the finer inner needle to be able to pull out the eggs. They have to have very short tubing so they don't get clots in the tube, and they have to use heparin to make sure the tubes don't block. But it is possible to do, but you really have to get good at it, and there's quite a learning curve.
Yeah, thank you, Anuja. There are a few questions for Sujata and Louis. I think we'll take it at the end of the session. And I now invite